Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. Hi there, my name is Mike Sullivan. I'm one of the instructors of Valor Medical Services, and welcome to ECG Interpretation 2C. Now, as you've been following along our courses, you'll notice we've gone through various ECGs up to this point, talking about sinus rhythms, rhythms originating from various places in the atria or the junction. In this segment, we're going to talk about AV blocks or heart blocks. You hear people talk about different types of AV blocks or blocks at the AV node. Well, we're going to get into those pretty well on this segment. Now, as we go through the core criteria, we'll talk about some of the different criteria for ECG interpretation. We'll describe the criteria associated with first degree, second degree, type 1 and type 2, and third degree AV blocks. We'll also talk about the clinical significance of each of these rhythms, what it may indicate to you as a provider, and some of the responses that we need to have based on what's going on with the patient. Now, in this rhythm interpretation program, we'll be using mostly 6 to 8 second strips. However, I will caution you, especially with some of the second degree or third degree higher level blocks, you may find that you need to print a much longer strip to try to determine a pattern or a sequence. So don't get discouraged if you can't pick them out originally off a 6 or 8 second strip like we have in class. Understand that many times we need to look at a longer strip to get a better idea of what the pattern is or what pattern emerges among the beats, and that will let us know what type of block it is. Now, if we flash back to section 1 of this program, we would go through some of the rules of interpretation. We talked about the PR interval. That's the distance from the start of the P wave to the beginning of the QRS complex. It represents the time from the start of the impulse at the SA node until it actually causes the ventricles to start firing. Ideally, the PR interval should be less than 0.20 seconds, or 5 little bitty boxes. If it's longer than 0.20 seconds, it's considered prolonged or delayed, and it indicates a possible conduction problem. This conduction problem would be a block, possibly at the AV node or at the AV junction. So we know what normal is. Now let's look at some of the deviations from normal that would make up our AV blocks. When a cardiac impulse leaves the SA node, it travels through the atria and arrives at the AV node or junction. There's supposed to be a brief delay at the AV node. That's normal. It allows the blood from the atria to drain into the ventricles, establishing the best possible preload for the ventricles so they can fire out either to the lungs or, in the case of the left ventricle, out to the rest of the body. However, in some cases, the impulse can be either delayed excessively or blocked completely. This would be what we call an AV block, or a nodal block. The blocking or delaying of the impulse will cause a slowing of the effective ventricular rate of the heart. If there's a delay along the way at the AV junction, that block will actually cause the effective rate to be less. Now, low-level blocks will likely not present any significant issues with perfusion. Maybe more significant blocks can actually present with serious signs and symptoms. The key to classifying these heart blocks is to look at how the P waves relate to the QRS complexes, or how the blocks relate, or what type of delays occur at that AV junction. So now, let's look at this rhythm strip and start putting it all together. If we go and we look, first thing we want to determine is the rate. Well, if we can count out from here for a 6-second strip, we'd say 1 second, 2 second, 3 second, 4 second, 5 second, 6 second, and we count back 1, 2, 3, 4, 5, 6, 7 QRSs. Okay, so we'd say maybe about 70 beats per minute. So far, so good. We look at the printout on the EKG strip, and it concurs with what we came up with. Now we look at the rhythm. Does it appear to be fairly regular? Meaning the gap between the R to R intervals, is it consistent pretty well throughout the entire strip? Now again, we can take a scrap piece of paper and march out and count out, but from just a quick eyeballing of it, it appears to be fairly regular overall. The next thing we'll look at is the PR interval. Now, when we get to the PR interval on this strip, we notice that it's a bit longer than is otherwise expected. For example, if we look at the PR interval from here, with the start of the P wave right at this point, coming out to the start of the QRS here, that's definitely longer than 5 little bitty boxes. It's actually about 5.5, almost 6. So we could say that it would be about 0.22 seconds. Again, if we marched it out from here, from this point here, out to this point here, again, it would be roughly about 6 boxes or so. So when we see something longer than 5 little bitty boxes, or 0.20, we'll say it's about 0.22. That would be a delay from when the impulse actually starts until the QRS actually starts. That delay would be what we call a first-degree block. Now, when we look at the QRS width, the QRS is narrow. It appears to be fairly consistent. We look at a gap here between the 2 green dots. It's roughly 2 boxes or so, which would be 0.08 seconds. Again, doesn't really stand out to be anything abnormal. So the only real difference in this rhythm from what would normally be a normal sinus rhythm is that first-degree block. As we come down a little bit further, we look at our P's to QRS's. Is there a P wave for every QRS? Is there a QRS for every P? Yes, there appears to be consistency between the P's and the QRS's. And so from that standpoint, we say, okay, there's 1-to-1 ratio for everything. All the P waves are upright. They all appear to be fairly similar in nature and morphology. So we know that it appears the rhythms are all coming from the same place. All the impulses are originating at the same origin. The only difference is it's a little bit delayed. So now if we were going to put together what this rhythm would be, we would call it overall a sinus rhythm with a first-degree AV block. The first-degree AV block signifies the delay greater than 0.20 seconds in the PR interval. So the clinical significance of a rhythm such as this, fairly low. Most of these are going to be fairly benign. It may make the underlying rhythm slightly slower. However, this patient, we had a rate of 70 effective from the QRSs, so it wasn't a big issue. Most likely, the patients may have an electrolyte imbalance, may just have a sinus SA node that's getting tired. It may be various things through there. But if the patient's not hypotensive or hemodynamically unstable, if they're not presenting with any really serious signs or symptoms, it's not going to make us work on or do much of anything. It may be an early indicator of a problem with conduction through the AV node. But again, if the effective rate is 70 and the patient's hemodynamically stable, we've noticed it, it's nice, we'll document it appropriately on our chart as a sinus rhythm with a first-degree block, but it really doesn't cause us any concern or any need to immediately treat the patient. Now, on the other side of that coin, if the patient was presenting with serious signs or symptoms, we'd have to manage those appropriately. For example, if they were having severe chest pain or hypoxia, we may wish to establish oxygen. If they were having issues with hypotension, we may need to address that. If they're altered level of consciousness, we may need to address their perfusion. But again, with a rate of 70 from the ventricles, it's not really going to be a major problem that we have to worry about on that patient. So overall, first-degree blocks, while they're interesting to note and nice to notice, and we need to document them, they're really not going to give us much unless the patient's actually symptomatic, at which point we'll manage that from there. Now, let's look at another rhythm here. Now, in this rhythm strip, again, we'll start off using our basic rules of ECG interpretation. We'll start by trying to determine how many beats per minute we have. Well, if we count out from, let's say this one right here, and we start our count off of this right here, and we say 1 second, 2 second, 3 second, 4 second, 5 second, we say 6 second, strip ends right here, and we count back with 1, 2, 3, 4, 5 QRS complexes in that 6 second gap would give us a rate of about 50 or so. If we count from later in the strip, we count from here, 1, 2, 3, 4, 5, 6. We count back, we have 1, 2, 3, 4, 5. Now there's a little bit of irregularity in here, so we've counted it twice, but we can be pretty happy with the fact of saying, okay, it's about 40 to 50 beats a minute. Now, when we look further a little bit, we see, yes, there's definitely the irregularity going on. The rhythm strip here is printing us, says 42 or 41 for an effective heart rate. Okay, that's close enough at this point. But we notice one thing about it is, yes, the rhythm strip is irregular, but it stays pretty regular for a while, and then it appears to just drop a beat in the gap right here. Much like down through here, it appears to drop a beat in the gap. So, not only do we have irregularity, but we seem to have a pattern to the irregularity. Now let's look at the PR interval. The interesting thing about the PR interval is, depending which P wave you look at, we will get different ones. For example, the PR interval gap in this first one here is going to be significantly more narrow than, say, the one up here, or would be more narrow than the one after that. If you look from beat to beat, from, say, beat 1, I'm going to tag here, to beat 2, to beat 3, to beat 4, in this group of beats right here, the PR interval seems to be ever increasing in duration. And then it drops a beat. We'll try it again. From here, the PR interval on beat 1, beat 2, beat 3, and beat 4 there. Again, the PR interval seems to be getting longer and longer and longer, and then we have a gap where it drops a beat. Now, where it drops that beat, we notice that there is definitely a P wave there, but there's no QRS for it. The same thing happens back here, where this P wave has no QRS for it. So we have a PR interval that varies between beats, and it varies a lot. It gets longer and longer on each beat until it drops a beat, and then it sort of resets itself and starts getting longer and longer and longer again. This is a very obvious pattern that we'll see, but you have to march it out. This is a rhythm strip here. It's about 8 seconds we're seeing on the screen, but you may need to actually look at a longer rhythm strip to pick up this pattern in some cases. The interesting thing on it is the PR interval varies. It follows a pattern, but it gets longer and longer until it eventually drops a beat and resets itself. Remember that because we'll hear it again, I promise. Now, as we look at the QRS complexes, the QRSs seem to be pretty much the same on all the beats. The QRSs are nice, they're narrow, they're under 0.12 seconds. This one here that we've got marked out looks to be about 0.08, seems to be pretty consistent. If we were to mark it here to here, we'd again say it's about 0.10, 0.12. Again, not really anything that jumps out at us. So it's got narrow QRS complexes, but the only abnormality with the strip is the varying PR interval and the periodically dropped out beats. Taking this to a step further, let's look at our P to QRS ratio. Well, we have P waves for all these QRSs, but occasionally we have these little orphan P waves we leave out here, such as this one here and this one here. So those two orphan P waves that we have that I flagged on the screen would both be dropped beats, and it would both be consistent with where the beat is dropped here. If we had a little bit more strip on here, you'd see this was a P wave here that seemed to have dropped, and there's a missing beat in here, much like these other two. So all the P waves seem to be upright and similar. However, some P waves just don't have a QRS with them. That would be a second degree block type 1. So as we look at this, your key criteria for determining the second degree type 1 block is, number one, we have an irregular rhythm that's dropping beats periodically. Number two, PR interval changing. And lastly, dropping out some beats for P waves that don't have a QRS with it. This would be called a second degree AV block type 1, or sinus rhythm with second degree AV block type 1. Now you can hear this expressed as various different names. I've heard several names for it in my career. But the key diagnostic criteria for it is the progressively lengthening PR interval followed by a dropped beat. Sometimes this may be called Mobitz 1 or Winky Bach. I've heard people say a good way to remember it is it goes on and on and on until it winks at you when it drops the beat here. So it goes on and on and on and winks, goes on and on and on and winks. That's great, however you remember it. Common causes for this can be electrolyte imbalances, possibly if the patient's on digoxin or Lanoxin, digitalis, things like that. It may also be due to increased vagal tone, maybe due to myocardial infarction. When we get into the clinical presentation and the clinical significance, it will largely depend on how frequently we have a dropped ventricular beat. In this case, we have about every fifth beat is dropped, so it's only dropped the effective rate into about 40 to 50 beats a minute. While that's lower than the 60 we'd like to see, on the other side of the coin, it's not necessarily as low as it could be. It's not a 30 or a 20. So 40 to 50 beats a minute, the patient may well be hemodynamically stable. But again, this is definitely something to watch and see how it progresses. In this case, we seem to have about what we call a 5 to 4 conduction, where there's 5 P waves for 4 QRSs. It means the vast majority is getting through. If it was, say, 3 to 1 conduction, that we were dropping 1 beat every third, that would decrease the heart rate a lot more, decrease the ventricular rate, which would be more prone to hypotension and symptomatic presentations. So, again, second degree type 1, Your diagnostic criteria is lengthening PR interval or changing PR interval that eventually drops a beat and resets, and it winks at you. That's type 1, Mobitz 1. Again, winky Bach is another term I've heard used for it. All right, let's take a look at another strip here. Now, we've got a 6-second strip here. Let's see what we have. Well, if we start counting for the rate, we'll start from right here. We count 1 second, 2 second, 3 second, 4 second, 5 second, 6 second. That would be about right here. And if we count back, we've got 1, 2, 3, 4 QRS complexes. If we count it again, we check, say, from right here. And we say 1 second, 2 second, 3 second, 4 second, 5 seconds, 6 seconds to here. And again, we count back. We've got 1, 2, 3, about 3.5 complexes in there. Seems to be we're pretty close on this end, and we're right on the edge over here. So it has an effective rate of about, I'd guess about 30, 35 a minute I'd give it. And when we look at the printout on the strip, it's giving us 35, okay? Now, we look, again, definitely bradycardic rhythm. Now, let's look at the regularity of it. Does it seem to march out? Well, yeah, it seems pretty regular for the most part as we go. Don't see any gaps that appear to be significantly different than the other ones. So we'd say it's a regular rate, regular rhythm. As we look at the PR intervals, what do we see? Well, each one of these PR intervals, there's a P wave here, and PR interval seems to be a little bit long, maybe. But then we've got a P wave here that doesn't have anything behind it. We have a PR interval here that maybe look a little bit long. We have a P wave here that, again, doesn't have anything behind it. We have a P to a QRS here, again, a little bit long, with the next P wave having nothing behind it at all. So now it seems to almost be that the P waves, they seem to be pretty well consistently conducted through on every other beat, but about also every other beat does not have a QRS for a P wave. And that's kind of weird. It's consistent on the beats do go through. All these, if you actually marked them out with calipers or with a paper strip, you'd see that these PR intervals from this one and this one here, and this one here, and this one here, all seem to be pretty consistent. But we're also blocking every other P wave from having a QRS complex. So it's consistent on the beats that go through, but it drops a lot of beats. If we look at our QRS, well, it's narrow. It's about 2 little bitty boxes, or 0.08 seconds. And we say that's fairly normal. So the biggest difference with this one is there are some P waves that don't have QRSs, and the P waves, they don't get longer and longer and drop. They seem to be consistent but drop. So what would we call this? This again would be a sinus rhythm as an underlying rhythm because it comes from the SA node with a second degree AV block type 2. We remember type 1, we changed our PR interval on each beat until we dropped one. Now we're not changing on each beat until we drop one. We're actually dropping beats, but the PR interval on the conducted beats are always consistent all the way through. And you can remember this phrase here, PR interval is constant on conducted beats or consistent on conducted beats. That is a textbook type 2 as opposed to the expanding PR interval that you would have seen on type 1. Now both second degree type 1 and type 2 will involve dropped beats. Both second degree type 2 and type 1 have narrow QRS complexes. Some beats are going through, some beats are not. Type 1, it gets longer and longer and longer and drops. Type 2 will actually have it where it's constant except on the beats that are blocked. And those are your big differences between second degree type 2 and type 1. Now, the key criteria, again, was it consistent or not? Now, the drop beats on this one were a 2-to-1 ratio. So we say, okay, there's 2 P waves for every QRS complex. You may have something that's blocking more beats. Let's say there's 3 P waves for every QRS complexes. Sometimes it may be a variable. You may have 2 in one section and 3 in another. But still, if it's constant on the conducted beats, we'd always say it's type 2. If it's lengthening, it would always be type 1. Now, this is an intermittent block. It may be caused by myocardial ischemia, heart disease, anterior MI. In these cases, the biggest problem we have is the ventricular rate is significantly slowed down. The more we slow down the ventricular rate, the more perfusion issues we have. Remember, the left ventricle is the business side of the heart. That's what does everything. So any differentiation between, well, the PR interval's doing this or the PR interval's doing that, it doesn't really come into play until we get to a rhythm like this, where it has decreased the underlying rate down to 35. A patient with a heart rate of 35 likely will not be hemodynamically stable. If they are, they won't be doing it for long. This is definitely something that we need to be ahead of. We need to be thinking about the possibility of either using pacer pads or something else, trying to figure out where we can get something done as far as possibly even a transvenous pacer. What ER do we have that's readily available to manage this? Now, it may be something treated with meds. They may be able to determine what the issue is that's causing it and fix it. Or it may be something that becomes hemodynamically unstable and the patient may get a pacemaker. At the end of the day, though, we know with the ventricular rate of 35, we need to focus on that and monitor that hemodynamic and that perfusion status very well. Okay, let's look at another one here. We have a P wave here. As we go through, we're going to figure out what our rate is. Well, starting from up here, we have 1 second, 2 second, 3 second, 4 second, 5 second, 6 second strip to about here, and we've got 4 beats in that time. So with 4 beats in that timeline, we say about 40 per minute is the heart rate. If we look a little bit further down here and we count it from this one, 1 second, 2 second, 3 second, 4 second, 5 second, 6 second, to down here and we count back. Again, we're about 4 beats in a 6 second strip. So we'd say it's about 30 to 40. This one gives it 32, okay? We look at the rhythm. Does it appear fairly regular? Well, the QRS complexes appear to be fairly regular on their own. They seem to be marching out. All the gaps appear to be consistent, as opposed to anything with a weird drop beat or something like that. So we'd say the rhythm is regular, underlying rhythm. We look at the PR interval. Well, it's kind of a mess. Here we have a very long PR interval. Here we've got a P wave with no QRS behind it. Here we've got a long PR interval, and it's got like a P wave right here in the middle of the QRS complex. Here we've got a P wave with no QRS behind it, a P wave with nothing really till there. P waves. It's interesting, if you note, you can march out the P waves on this and they will all be regular. For example, if we march from this P wave to this P wave here, 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 they all appear to be fairly regular. On the other side of that coin, when we march out the QRS complexes, they all appear to be very regular also. So the P waves are regular and the QRSs are regular, but there's no consistency between the two. There's no correlation. Sometimes we have P waves right in the middle of a QRS. Sometimes we have them out here all on their lonesome doing nothing. Sometimes we don't even have a P wave and we have a QRS. This P wave is right in the start of the QRS, and over here we've got a P wave in the middle of the QRS. So when we look at the P waves and the QRSs on this, we'll say there's no correlation. They're both regular unto themselves, however, there's no connection between the two. The QRS complexes are all nice and narrow, so we'll say they're about a 0.08 seconds or 2 little bitty boxes. And we come through, with the PQRS, there's no correlation. You can march out individually on these. The P waves will all march out. You can march out the QRSs, and they'll all march out. But there's a complete wall or a complete block between both of them. So if we're trying to identify this rhythm, this would be a third degree or complete heart block. The reason we say it's a complete heart block is there's no communication or pattern between the P waves and the QRSs. So as we go through, it's like, okay, there's nothing in between them. This is also known as a complete heart block. So now, if we look at the P waves, we look at the QRSs, they're typically regular to themselves. The P to P distances are consistent. The R to R distances will be consistent. The biggest problem this rhythm will present for us is the slow ventricular rate, and the lack of diminished atrial kick will normally present with a very critical patient. In this case, what's happening is the P waves are firing, but nothing is making it past the AV junction to fire the ventricles. The ventricles are doing their own thing. They're totally no communication whatsoever. So now let's look at the summary of all the rhythms we've talked about and all the blocks. We have our first degree block. Normally not too significant. The biggest difference is we have a PR interval that's longer, even if it's just a little bit longer than the 0.20 seconds. So there's a little bit of an extra delay. Usually it's pretty regular. Your QRSs are going to be narrow most of the time. We have our second degree, AV type 1, which progressively widens until it drops a beat. Remember, type 1 is Winky-Bach or Mobitz 1. We have our second degree type 2. Now, second degree type 2, it may be regular, it may be slightly irregular, but the big difference is that our PR interval is constant on beats that are conducted through, but it will drop some beats. We know that we'll have an unequal number of P's to QRSs because of these drop beats, but the beats that go through on time. Lastly, we have our third degree or complete heart block. Now, the PR interval on this I refer to as chaotic. There's no connection between the P waves and the QRSs. So we can march out the P waves and see how they line up. Okay, they're consistent. We march out the QRSs. They line up. They're all consistent, but they're probably going to be a little bit slow because it's a rhythm that's originating below the P waves. We know that we'll typically have a wider complex QRS also with a third degree block because it is a wider rhythm. It's originating below the ventricles. There's no correlation between the P's and QRSs, thus leading to the fact that there is a complete blockade between them. Alrighty. I know we've covered a lot, but in closing, when determining how problematic any of these rhythms is, focus on how the block is affecting the ventricular rate and what that effect is having on the patient's perfusion. In light of the fact that a lot of the blocks are determined based on a pattern, you may need to print a longer tracing. The P waves and the QRSs, for example, on that third degree block, you may need to print a 10 or 20 second strip to march them all out and figure out how the pattern lines up. Or to figure out whether it's second degree type 1 or type 2, you may need to look at several series of P to QRS ratios and look for a PR interval change or something that's different. Or, in the case of a second degree type 2, look for something that's consistent on all the conducted beats. You may need to take a bigger sample to determine how that plays out. Overall, again, focus on how it's affecting the ventricular rate and how that's affecting perfusion. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.